Welcome to an overview of falls in hospital and their prevention. My name is Terry Haines. Falls are generally considered to be quite humorous, particularly when they happen to politicians, to elite athletes, and also to celebrities. However, in hospitals, they are one of the most common adverse events that are recorded. When do falls happen? Falls happen across the day and night in the hospital setting. This data was taken from a rehabilitation ward to emphasise peak periods of falls that occur early in the morning, starting from about 6 o'clock a.m. going through till 10 o'clock a.m., a dip in the rate of falls at lunchtime, and a second peak later in the afternoon going into evening. Where do falls happen? Falls can occur anywhere in the hospital environment, but 2/3 of falls happen by the bedside. Why do falls happen? When we ask hospital staff why falls occur in hospitals, they tell us that patients are not aware that they can't do things that they used to do, that subconsciously they are in denial about their loss of ability, and that they require supervision, but that they are reluctant to ask for supervision. When we ask patients about why other patients fall, they say they try to do something that is too hard. This has led us to conceptualize falls using a framework whereby it is the balancing of the ability of the patient against the demands of the task that is critical in ensuring that patients do not fall over during hospital. Central to this is the decision-making of the patient in choosing which tasks to attempt to perform relative to the amount of ability they have. In hospital, many patients have reduced mobility ability because of the disease or because of the surgery that they had that brought them into hospital. If they try to perform tasks that they previously performed, the demand will be too great, and there will be a fall that ensues. However, with improved decision making, they can attempt a smaller set of activities that match the level of ability that they presently have while they are in hospital. However, there are some activities that still need to be performed, such as getting dressed, going to the toilet, getting showered. These demands may still be in excess of the ability the patient has. Receiving assistance from hospital staff is critical in maintaining the balance. When we ask patients about why they fall over in hospital, but when talking from their own perspective, they tell us, "Oh, the bathroom is too crowded, it's slippery." They prefer to blame environmental factors. Now, even if this is true, that environmental factors increase the demand of certain tasks, it is still their decision-making which is central to the choice of trying to perform that task if they feel that they can choose not to perform that task. So how does this fit with what we already know about falls in hospital? Well, we know that in the early morning peak, patients are performing a lot of activities that put themselves potentially at risk. They're getting showered, they're getting dressed, and they might be preparing to go to different therapies. Our trough at around lunchtime is when patients are often sitting down having lunch, and they're not performing activities that are going to put themselves at risk. Also, we know that patients feel that walking to the toilet or to the bathroom because of the distance is a reasonably high risk activity, and they prefer to ask for hospital staff assistance to perform these activities. However, they view activities performed around the bedside as being much lower risk activities, and therefore they are tempted to perform these activities on their own without the assistance from hospital staff. What do we try to do to prevent falls in hospitals? There are many activities and strategies that you will see on a hospital ward that have been put in place to try and reduce the risk of patients falling over. But do we know if they work? Well, if we look at these one at a time, bed rails, for example, we just don't know if these work. There is an absence of randomized controlled trials that have investigated this intervention. We think they may reduce falls by stopping some patients from being able to get out of bed and put themselves at risk of falling, but we also think they may increase the harm from falls because some patients will still try to get out of bed, go over the top of the bed rails, and then be falling from a higher height. Low beds are beds that go all the way down to the ground level. One randomized controlled trial has showed no effect on falls from this intervention. This trial was a large trial and was conducted in Queensland. Bed or chair alarms are used to try and let staff know when patients are moving around on or off their bed or chair. 2 randomized controlled trials have shown no effect. Each was a very large randomized trial. One was conducted in the United States and one was conducted in the United Kingdom. Both showed no effect of this intervention. Falls risk signage is commonly used. However, there have been no randomized controlled trials of falls risk signs in isolation. They have been used in randomized trials of multifactorial interventions that both did work and did not work. There is one study of falls alert bracelets, but this study was ceased prematurely due to a non-significant increase in the rate of falls, leading to the investigators to cease this trial. Patient sitters are commonly used, but we just don't know whether these work or not, as there is an absence of randomized trials that have been performed. Providing patients with a falls prevention booklet or video, there is one randomized trial that has shown no effect on the rate of falls from providing this sort of information. This trial also demonstrated, in a subsequent publication, that providing a booklet or a video alone may increase depressive symptoms in these patients. Face-to-face patient education. There have been 2 randomized controlled trials looking at this intervention in isolation, one of them targeting cognitively intact patients. There have also been 2 randomized trials as a part of multifactorial interventions. All these trials have shown 30% reductions in falls or more. The most recent trial published in The Lancet showed a 50% reduction in falls if this education was provided to cognitively intact patients and the information gained used to inform falls prevention practices across the ward. Importantly, this intervention is the only intervention with credible cost-effectiveness data demonstrating the value of this intervention. So what was so magical about this face-to-face patient education? Nothing. It used relationships to empower patients to improve their decision making and to help them to receive assistance from hospital staff. This intervention is what you'll be learning more about during this workshop.